Good afternoon. I'm very happy to see all of you here. I'm Claire Brindis, and I'm the director of the Philip R. Lee Institute for Health Policy Studies. And one of the wonderful things that the Institute is involved in right now is a partnership with the University of Michigan and the University of Pennsylvania, where once a year we invite junior faculty to come and spend what is the equivalent of a visiting professorship. Now, oftentimes, visiting professorships come at a much later time in people's careers. And through our partnership, we decided that it was really important to provide these kinds of opportunities earlier in people's careers so that they can visit other campuses, have the exposure, and have the opportunity to meet with individuals in those campuses that have similar interests or parallel areas, and where potential collaborations can also emerge. So we're very excited that to invite and welcome Dr. Laurie Buis to our midst today. And Laurie is an assistant professor at the University of Michigan. She has a background in psychology and mass communication, but she has been really focusing now on the use of behavioral interventions, technology, and effective strategies that reach a wide variety of different audiences, particularly around the treatment and management of chronic health conditions. Laurie will tell you a little bit more about herself, and I'm just really delighted that you're here. So welcome.
Thank you for having me. I'm so pleased to be here, and I'm so pleased to get to talk to you guys a little bit today about some of the work that I do. I'll just put it out there right up front. I'm a very informal person. Maybe it's the Midwest in me, I don't know, but feel free to ask questions as they arise. And if I'm talking too fast, tell me to slow down. So, yes, I'm an assistant professor. I'm in the Department of Family Medicine at the University of Michigan. I also hold an appointment in the School of Information where I teach in the Human-Computer Interaction program there. So I'll tell you a little bit more about my background in just a minute. And just to let you know, I'm going to talk to you today about some ongoing work that I have in the world of hypertension management with digital health. And really, the focus of my talk today is to help share some of the lessons that I've learned from working in this space with you all. I'm often asked to consult on digital health projects, and there's a lot of stuff that I wish people entering into the world of digital health knew. And I've spent a lot of time learning some of this stuff, and I'm hoping to pass on some knowledge to you. So I'd like to start out by telling you a little bit more about myself. I am a Michigander, born and raised. I have lived all but 6 months of my life in our great state of Michigan, and I've spent time at all 3 of our major academic institutions. I started out my career at Michigan State University as an undergrad. Go Green. Go Green. I did my master's at the University of Michigan in the department where I now teach, which has been a very strange experience, but also very rewarding. I earned my doctorate in mass media from the Department of Telecommunications and Information Studies at Michigan State University. Again, go Green. From there, I did a very odd thing for someone in the social sciences. I went on to a postdoc at the Ann Arbor VA in Health Services Research and Development. I've always worked in the context of healthcare, and at the time, I was I was the second person in my program to ever go into a postdoc, which a lot of people thought was a failure on the job market. And for any of you who are postdocs or thinking of becoming postdocs, it was one of the best decisions I ever made for my career, and I really welcomed that opportunity. I am now no longer at the VA, although I still affiliate with the VA, and I do some work with them with digital health as well. From there, I thought, this was at the height of the recession in 2009, I thought I would never get a job because every tenure track position I applied for was frozen. I eventually found a position at Wayne State University where I worked in the College of Nursing. And I am now back at the University of Michigan in family medicine. So I worked with nurses, I work with physicians, pharmacists are my new favorite people. I work with them quite frequently on our chronic disease management studies. And I'm even starting to work with dentistry. So there's very few health professions that I have not touched. And I think we're all trying to do some of the same work, so let's all do it together. I consider myself to be an interventionist. I love to develop interventions for chronic disease self-management, and I really focus on consumer-facing informatics. I'm interested in understanding how we can use the tools that are already at our disposal, leveraging the devices we already have in our pocket to accomplish something in terms of better health outcomes. So why do I do what I do? I'd like to introduce you on the upper left to my favorite person in the world. This was my grandmother Gladys, who I named my youngest after. And she passed away a few years ago, and she's still with me every day. And she lived with type 1 diabetes for the majority of her life. And she was so proud of the fact that when she died, she still had all of her arms and legs and fingers and toes, and she was fully intact. And that was due to a lifetime of vigilant chronic disease self-management. And watching her through my formative years, watching 30 years of logging glucose, insulin, calories, and then carbohydrates as she moved to a pump, she took impeccable care of herself, and she had all the tools in the world to do so. I'm a child of the 80s. I have always had a computer in my house. I have never known a time where there was not access to a computer in the home. And we helped her make spreadsheets. We helped her with everything that we could do so that she could maintain the tight control that she needed to live her healthiest life. And as I watched with spreadsheets and programs like Excel, I kept thinking as technology was getting more advanced, there's gotta be a better way. Let's see. So one of the other interesting things about me is that I grew up outside of Flint, Michigan, which many people know as the birthplace of General Motors. It's Buick City, and people in the city of Flint take great pride in their city. And unfortunately, more people know about Flint now than they ever used to know about due to the Flint water crisis, which is still very much something that impacts our city and my family and friends. And I grew up about 10 miles down the road from downtown Flint. And even though I was not a native Flint resident, people in the region in Genesee County, Michigan take very much pride in Flint and being from Flint. And with that being said, there were so many opportunities to go into Flint to help what has been, for my whole life, a dying city, a very, failure to thrive, very poor city. And we just spent a lot of time doing outreach and volunteering opportunities, and it was very much not lost on me that there was a very stark dividing line between the town that I grew up in Flint, Michigan. You didn't go into Flint on your own, or your parents would kill you. You didn't cross US 23, the expressway, because everything started to go south very quickly. And thinking to myself about the tools that my family had at their disposal when 10 miles down the road, chronic disease self-management was a very different story, has had a lasting impact on me. And a lot of the work that I do now is motivated with trying to reduce health disparities with chronic disease self-management. And I started my career doing work with internet-mediated interventions. And as technology has evolved, I have started to do more mobile health interventions. I've had great success in getting my work funded in the world of hypertension, and that's a lot of what I'm going to talk to you about today. But I also do work with mental health and diabetes management and things of that sort. So that's a little bit about me and why I do what I do. So hypertension is a major public health concern. About 78 million American adults have hypertension. That's about a third of our adult population. And of those, only about half have their blood pressure under control. Hypertension is very costly to our country. We spend about $46 billion annually in terms of healthcare services, medications, and missed days of work. Hypertension is a key risk factor for heart disease and stroke, which are the first and fifth leading cause of death in this country. And there exist tremendous disparities in terms of hypertension management. The burden of hypertension is particularly onerous on African Americans, And there are great race-related disparities when it comes to hypertension. Not only do African Americans suffer from greater prevalence of hypertension, but they have an earlier age of onset and they suffer from more disease-related complications than age-matched whites. And so I mentioned that I worked for many years in the city of Detroit at Wayne State University. This was a problem that surrounded us on campus. The city of Detroit is about 82% Black, and uncontrolled hypertension is incredibly prevalent in the city. For the last 60 years, hypertension treatment recommendations have been largely the same, and they're very heavily based in lifestyle and behavior modifications. And that's a lot of the work that I do, which makes hypertension a perfect disease state to work with for the type of work that I do. So what do we tell people to do? Eat less sodium, increase your physical activity, lose weight if you need to, which most of us do, lower alcohol consumption, quit smoking, and take your medications that have been prescribed. All of those are lifestyle factors. And one of the things that I've learned in doing lifestyle and behavior change interventions over the last 15 years is that behavior change is really hard. It is really hard to change the habits that we have and to sustain those changes. And I talked about how Blacks are at much higher risk for problems with hypertension, and the disease burden is so much greater in that community. Well, it turns out that making behavior changes is also more difficult in this population, as fewer African American people are reporting making the lifestyle and behavior changes and having the adequate supports to do so. So if we're really going to make a difference in our community in Detroit, hypertension is a wonderful thing to start working on. So I want to talk to you a little bit about some of the work that I've been doing. The first study I'd like to tell you about is focused on an app called MyBP. It's kind of a play on words. MyBP is in my blood pressure, as well as MI is our state abbreviation. And MyBP is a fully automated, comprehensive lifestyle and behavior change intervention. It incorporates the use of Bluetooth-enabled blood pressure monitors and Fitbit devices. It also, within the app, provides medication reminders, sodium tracking, goal setting, tailored messages, and graphs data visualizations of the behaviors that we're tracking. And we're using this app within a population of uncontrolled hypertensive African Americans recruited from 2 emergency departments in Detroit. So again, this is a really highly prevalent problem in our city, and this is our approach to helping manage it. We're currently testing the use of MyBP against enhanced usual care. What do we mean by enhanced usual care? Well, one of the guidelines for managing hypertension is home blood pressure monitoring. And so regardless of whether you're randomized to the treatment or intervention group in our trial, we provide everybody with a home blood pressure monitor. Not everybody has access to those devices in our city, so we do our best to make sure that they have at least the minimum tools to help take care of their condition. So again, we have an ongoing randomized controlled trial. We're recruiting 396 individuals who are randomized equally to our treatment and our enhanced usual care conditions. And again, I mentioned we're recruiting African American adults with uncontrolled hypertension from 2 EDs in Detroit. And we have kind of an interesting study design where we're intervening on people who are in the emergency department. And as you might imagine, they are starting out with high blood pressure because they're in the ED. There's something going on. So we bring people back 2 weeks later to do we enroll in the ED at what we call week -2. We bring people back 2 weeks later for secondary screening to ensure that we're really finding the people who have uncontrolled hypertension. And we do our baseline measures there at week 0. And then we bring people back 2 weeks later from that to randomize them into the trial. So we have a very lengthy washout period to make sure we're hitting the right population that we need to hit. We bring people in for medication titration at weeks 2 and 8, and then we collect data at 3, 6, 9, and 12 months. So it's a 1-year trial. To date, we've randomized 84 people, so we're about 20% of the way. Oh, it's slow, but we're getting there. So it's, as you can imagine, it's a tough population to work with. The primary outcome measure for this trial is blood pressure control at 12 months, but we're also interested in looking at other behavior changes. We're looking at physical activity, we're looking at medication adherence, we're looking at sodium reductions in dietary sodium. So really, we're trying to intervene on all of those behaviors that I mentioned that we've been telling people to do for 60 years. Do we know which of those functions people are going to have the best success with? No, we have a huge package that we're throwing at them, and at the end, we hope to start looking for patterns of use to see what has the most success. And I'd be happy to talk more about this specific trial if anybody has specific questions. Yes?
For the nutrition and salt information, is that just self-report?
So we have it's an excellent question. The question is the salt piece, is that self-report? And for the use within the app, yes. But rather than getting people to log every food, who here, by a show of hands, has logged food? Who here enjoyed it? Who here did it for more than like 2 weeks? Did you fall off the bandwagon though eventually? And did you get back on? Yeah? So it's hard. Self-monitoring and logging of food is very tough. So what we do is we take an adaptive approach, and rather than asking people to log every food that they eat, and then we estimate their sodium intake from that, we have a list of high offender foods. Processed foods, frozen foods, prepackaged, canned soups, things like that. We have a list. It's about 35 to 40 different foods that are broken up by categories. And we ask people to tell us, how many times did you eat this today? We don't really talk about serving size because serving size is really difficult to understand and to get correct. So we just want to know the number of times that you ate these foods. If you eat potato chips at every meal, we want you to tell us you ate them 3 times that day. And then what we do is we do our goal setting on the number of foods that they reported eating. Any other questions about the trial before I move on? Yeah.
This is super interesting work. Did you guys do any formative work out of usability testing and sort of talking in focus groups about which features people might find most engaging? Some people are interested in data, some people are not. But did you do any of that?
Yes and no. We have a community advisory board in Detroit that we work with that helps us tweak all parts of the intervention. But really, we know from all of 10 years of work and other research studies that there's a lot of different kinds of people who find success in a lot of different approaches. And so we've essentially made a very concerted effort to throw every digital tool we can at people, and we will look on the back end at what patterns of use there were. Because I suspect not every pattern is going to work for every person, but perhaps there are functions that are more associated with good outcomes in the intervention. Yeah?
Did you assure that everyone had an iPhone or a tool, a phone?
Having access to a smartphone is an eligibility criteria. Our platform works on both iOS and Android devices. And I'll talk a little bit more about why that's complicated in a few minutes. Yeah?
Well, now I'm curious about what percent of people do you know would disqualify just because they didn't have a phone.
Access to phone is not our primary problem. We find from some of the pilot data that we collected, about 90% of our patients have smartphones. So there's certainly some who are excluded, but that is by no means the chief. Yeah. Yes?
I'm curious why you decided to recruit from the emergency department instead of primary care practice or some community setting.
So the access to primary care in the city of Detroit is appalling. And if I was a resident, I would not seek my care there, honestly. From a lot of the pilot data that I collected in the city of Detroit while I worked down there, even when there is access to primary care, the type and the quality and the barriers to actually getting the encounter are so different from what I experienced 30 minutes down the road. I sat in a lobby once conducting a lobby survey, and I watched an individual sit there for 3 hours to get a paper referral to ophthalmology. I would never stand for that in my care. And the fact that we ask people to do that it's really heartbreaking for me to see. And when we wonder why there's so many patients in our emergency departments, a lot of people are receiving their care in the ED in Detroit. People may not have money, but they're not stupid. There are giant billboards in the city of Detroit that will tell you what the current wait time is at all 8 DMC-affiliated hospitals. And if I'm not feeling well and I want to be seen, I'm going to go where I can be seen in 29 minutes or less. I'm not going to wait 3 hours. So finding participants for our research study, it was really important to us that we went to the place where people are going to for care. And in our city, that is the emergency department.
DMC.
Detroit Medical Center, sorry. We also are expanding out into community health fairs because, again, people are going to screening events. They're going out to community health fairs because they can get quick answers to things. Are they getting treatment? No, but they can get referrals to treatment from there. But we find that a lot of our emergency room docs, in a sense, end up acting as primary care providers as well. Yes?
Just one other question. You mentioned that you do some medication management as
Yeah.
well. And it sounds like that's probably because the primary care network is so horrible in terms of access. So
Yeah.
you're not relying on them. But it sounds like that means the intervention is not just a mobile health intervention, but also a medication management.
Correct. Correct. There is meds prescribed. We have study physicians who work to manage hypertension across our participants for the year. And in often cases, if there is access to primary care and patients do report having a primary care provider, we do work with their primary care provider to say that we're making recommendations to change treatment or to titrate up or down. So we do work with primary care physicians when they have them. Yes?
I'm just curious about how many of them are Medicaid or Medicare.
Most. Yeah. I mean, there certainly is some private insurance in our participants, but the vast majority are Medicaid, or even there's still a few handfuls of uninsured. Yes?
So then the medication recommendations, are those made both to the people who are getting both to enhanced
Yes.
care and the
Yes.
part of the enhanced care?
Yep.
Okay, yeah.
Okay, the other study that I want to talk to you about is what we call BP Track. And in the MyBP study, it's a fully automated intervention where people come in, they do have access to the physicians on the study, but again, it's largely an automated system. And we wanted to know, when we think about the future of mobile health and we think about what does healthcare look like 20, 30 years down the road, there's this vision of what mobile health will be and what it will do. And that's putting data into the hands of the clinicians who are acting on it. And we wanted to start understanding what happens when we do that? What happens when we put that data from home blood pressure monitors into the hands of individuals who can act on it? So we conducted a pilot in primary care at the University of Michigan. One of the things that I think is fantastic about our clinical sites is that out of our 6 family medicine clinics at U of M, all 6 have embedded clinical pharmacists, and we should be leveraging them to do what they can do to help us in chronic disease management. And our clinical pharmacists have been helping to manage diabetes for years, but hypertension is an area that a lot of physicians have been slow to refer their patients to the pharmacist for management. And so we have an institutional effort to start having pharmacists take on more hypertension management. And so we put home blood pressure monitoring data into the hands of the embedded clinical pharmacist who is tasked with overseeing hypertension management. The BP Track intervention was a 2-sided intervention where there is the patient experience with a patient app. There's some screen grabs there where you can see visualizations of home blood pressure data. There's also educational messages and medication reminders. And on the other side, we've got a clinician-facing app. The data from the patient app flows through the cloud, and then the clinician can pull the data down into this clinical app that presents a dashboard patient view that's color-coded by how patients are doing in terms of their home blood pressures. They can do deeper dives where they look at individual patient readings, individual patient graphs, they can set individual patient goals, and they can message patients directly through the app. So again, it's a two piece of software system. We conducted a small pilot study with a one-group pre-post design. Again, this is preliminary pilot work. And we had 15 recruited patients, of which we completed 3-month follow-up visits on 13 individuals. And I know this is a really small pilot compared to the MyBP project, but I think our team is just as excited about what we found in this, because this is the type of work that we need to do institutionally and beyond to start realizing the future of mobile health. So we did find that for the 13 people who completed our follow-ups, we had significant reductions in systolic and diastolic blood pressures. For most patients, I think all but 2, all but 3 had significant reductions in both. And on the whole, we found about a 6.62 point reduction in systolic blood pressure and a 5.65 reduction in diastolic blood pressure from baseline to 3 months. Above and beyond that, we found that the patients who used the intervention found the experience to be highly acceptable, with 100% of participants reporting that they thought that they would recommend the program to others. They liked knowing someone was watching their blood pressure. They were satisfied with the program, and people really felt that the program was overall beneficial to their health. On the flip side, I'm going to talk a little bit more about our experiences with both of these trials as I move into the next part of the talk. We also found that there were a lot of things that came out that we didn't really anticipate in terms of how do we do this in the real world? What are the ethical implications of this? And I'm going to talk a little bit more about that as we move into the next part. Any questions about, yes?
Can you say a little bit more about who the coaches were and what kind of training they received?
The coach was a clinical pharmacist embedded in our so a PharmD who practices within the clinic to begin with. So, yes.
And I was curious about the educational messages that were being sent to the patients. How often and what was the content?
The content is your pretty basic American Heart Association type content, tips for healthier foods, dietary substitutions, the importance of physical activity, tips and tricks for becoming more physically active, things of that sort. Pretty limited in content because we tried to stick within push notifications of about 240 characters. So think text messages, a little bit lengthier, but think a text message.
Every day?
Random times. If you think about it, if you know that a message is coming at 8 o'clock on a Monday, you know kind of what it's going to say. So we did random within bands. We had not earlier than this, not later than that, but some randomness to it to keep it fresh.
Just can you say a little bit more about your population? In the other study was from the emergency department, your patient group came from?
Primary care, uncontrolled hypertensive patients. No race restrictions, though.
And which primary, I'm so curious, because you were like, the primary care system.
But this was not, this is not in the city of Detroit. This is in Ann Arbor at our primary care sites. Yeah. So, your general primary care population. This particular clinic that we worked with is in Ypsilanti, Michigan, which has a little bit higher diversity than Ann Arbor proper, but at the same time, I don't want to say a fairly affluent community, but because Ypsilanti is probably our least affluent of our sites, but still pretty well off. So what have I learned from all this? What do I want to share with you guys about the work that I've been doing in the last 10 years? What is it that I want other people to know as they start to move into the world of mobile health research? I've broken down my lessons to you all into 12 lessons that pertain to us as researchers, things I want you to know about patients, and things that I want you to know about providers and the use of mobile health. So, lesson 1. Managing vendor relationships is one of the hardest things that you're ever going to do if you're working in the world of mobile health and you're not building your own interventions. I tried to build and develop my own interventions, and 10 years ago, it flew a lot better than it does today. I am not a developer, and my ability to maintain and secure and keep an intervention working properly is just really difficult. 10 years ago, I feel like you could give somebody something that was held together with spit and duct tape, and they'd give you the benefit of the doubt and they'd use it. But the consumer experience now with what's available for free is so slick and so good that my ability to compete with that is just very limited. So I'm no longer in the business of developing my own interventions. And people are always shocked when I talk to them about how do you find the right vendor. That's really important. Having someone who will help you iterate and get what the experience that you need. People often come to me and say, I got a quote from a vendor and oh my God, I can't believe how much money it is. I was like, well, if you're gonna do this in-house, you're gonna have to pay salaries of faculty and students who are gonna oversee the development, and who's gonna make sure that when this goes down at 2 a.m, which it inevitably will, who's gonna get it back up and running? So, I push back a lot and say that those infrastructure costs, if you're building in-house, are actually really high as well. So to encourage people to think about the trade-offs of working with a third-party vendor. I've also, when working with a vendor, I've never hit a timeline that they promised me. It's just like a fantasy and it's never gonna happen, I strongly believe. And the delay could be not on their end, it could be on your end. There's just a lot of moving parts to get things working correctly. So having realistic expectations about what needs to happen and how you're gonna get there. How do you know if you're talking with a development team that what they're telling you is accurate? Find someone who can help you navigate those relationships, because it's my experience that most healthcare professionals are not well versed in the world of development, and the world of developers are not necessarily well versed in the world of healthcare. And so having someone to help translate the language between the two and understanding what does missing data look like? Is it a period or is it a zero? Because that can have a real big implication about what you're doing with your data at the end of the day. So there's a lot that goes into building and developing mobile interventions, and managing vendor relationships is really important. And I think one of the biggest problems that we've ever experienced is even when you find the best fit and you find the best vendor, that's not to say that something is not going to come up tomorrow that changes the landscape of what they're doing for you. Industry moves very fast, and we don't in academia. And I think one of my biggest challenges I've ever faced was when I had like the world's perfect vendor and everything was going so well. And then they were chosen to be the platform for the 1 million cohort from the Precision Medicine Initiative. And suddenly my $100,000 contract is nothing compared to NIH's $70 million contract. And trying to get NHLBI to understand that I can't compete with that has been very difficult. So vendor relationships are often difficult. Lesson number 2, selecting your technology is a really big and important decision. When someone says to me, I want to build an app, the first thing I ask them is, why do you want to build an app? Everyone builds an app. And if they can answer me with a good answer as to why they want an app, then I'll ask them, well, what do you want it to be on? Do you want an Android app, an iOS app, or do you want it to work on both? Because that's going to have big implications for cost down the line. And it's interesting because, oftentimes it can be really easy to work just with iOS because things tend to work in the iOS environment. But that's not where at least the people in Detroit are. The people in Detroit are mostly using Android phones. And understanding that the peripheral devices that you work with may not interface super well with all of the different builds and all of the different technologies that are out there. And there's nothing more frustrating to find out that your device manufacturer didn't update their firmware, so now your blood pressure cuffs don't talk with the app, which don't talk with anything else, and it's not anything you could have done, and your developer's trying really hard to get everything up and working, but sometimes it's not even something that they can control. So there's a lot of moving parts, and understanding what the pros and cons of the different technologies you select is a big, important decision. Technology can also shift around you, and how are you going to respond to that and adapt to that? We had, like I said, an instance where there were changes in the Android platform and our device firmware was not updated. And how did we fix that? That's how do you handle when the world shifts around you? So those are all interesting experiences that we've had. Also, we work with Fitbits, and guess what? Our Fitbit device has been discontinued. How do you respond to that? Again, there's a lot of challenges. I have one study that I've been working on in the VA for 5 years now. We had to go through 4 different fitness trackers before we actually got the money for the grant because the companies kept folding or getting bought, and how do you respond? So technology selection is pretty big. Long-term follow-up in this space is really important, but it's also super difficult. And I have to think to myself, with a trial of 400 people for my BP, it's going to take us like 5 years to finish this study, if we're lucky. I'm hoping that we can finish it before 6. And how relevant is the data going to be at the end of 6 years when the world has continued to march on? So that's a really tough question. And you have to ask yourself, is your vendor even going to be around in 5 years? What's going to happen if they get bought up, and how are you going to respond to that? Again, all really important questions that you don't really think about on the first pass when someone says, I want to build an app. So the last point that I have learned really comes from my experience reviewing grants for both NIH and NSF, and it's that grant reviewers want to see feasibility. I consult on so many projects where people are like, I found this vendor, they've got no experience using them, they don't know what they're doing, and they think, but they've worked in a cancer population before. Well, the cancer population is the window dressing. You want it to work with a vendor that knows how to do the core function that you're trying to get accomplished in your program. So even if you've never worked with the vendor before, to have a history to show the relationship, how can you prove and show that they can actually do the work that they're contracting with you to do? So it's surprising and shocking to me how often I read grants and review grants where I have no belief that the vendor can actually do what they said they were going to do with the team. And it's not to say that they can't, but if you don't provide the evidence to suggest that they can, you're not making a very strong case for your funding. So those are just some of the researcher lessons I've learned. Let's see. In terms of patients, I've learned that mobile approaches are really fantastic to patients. Patients love it. They love the sexiness of technology. They think it's cool. I have never once asked people what they thought about it and had someone say, like, it sucked. I mean, if you ask people if they like the intervention, hands down, all but like 4 people in my entire career have said that they loved it, they would recommend it to other people, and that says to me, maybe we're not asking the right questions. So be careful about how you ask those questions, because if you just ask people if they're satisfied, they're always satisfied. And that they can't be the case because you find that people aren't engaging. They're not changing behavior. So clearly, there's a disconnect between what they're telling you and their actual experience. Patient understanding of technology is often really limited. We work with a lot of populations that we're getting out of the emergency department and out of primary care clinics. And when people say, I want to put this app into the clinic, I ask them, well, who's going to help you troubleshoot when they don't know their app store password? And they're like, well, I don't know. Well, that's a really important question, because pairing devices, logging into different applications, making changes within the settings, those are actually some pretty sophisticated things that we're asking patients to do. And you need to have the personnel on staff who can help be responsive to those questions, because they do come up. And even if you pair technology in the office for people, that will eventually become unpaired. And walking someone through the phone how to repair can actually be really complicated. So being prepared to handle these very basic technology issues is really essential. Patients often think you're watching them like a hawk. Even though you can tell them until you're blue in the face that these are automated interventions that exist out in the world and they run on their own algorithms, there's an understanding among many people that someone's watching their data. And not only that, but like the number of patients who've said to me, you guys really set really great goals for us. I don't know how you spent so much time calculating goals. Like that, it's just mind-boggling to me that how many people think that there's a human person on the other end generating this stuff. So keep that in mind as you're developing your intervention and how you handle participants. And it raises some questions. If somebody's living out there with really high blood pressures that are in a really scary range, and they think that someone's watching over that data, that raises some real hard questions about what is our responsibility with the data. Certainly we can develop algorithms to help highlight and find the people who are having issues, but what do we do and how do we handle that? Engaging and retaining patients is really hard. This is not just from mobile health research, but going back to internet-mediated research as well, going back the last 20, 25 years. We see this really typical pattern where we can get people really gung-ho in weeks 1 and 2, and then somewhere around week 2 and 3, we kind of peak and plateau, and then we plummet. And an even bigger kick to the pants is if you're doing like a text message intervention where you're obligated to send messages every 4 weeks reminding people how to opt out, and then you see bumps in engagement because they're all opting out. Like that's really disheartening. But at the same time, I think it raises a really big question about how do we engage people to keep them coming back? Because if you don't have a sticky intervention that they're going to engage in, it's not to say the intervention didn't work, but if we have to get people back and engaging over time. In our communities that we work with in Detroit, participation in my study is not their priority. Don't get me wrong, I know people love the $25 they get for coming in, and I'm just happy if they can really engage half the time that I want them to engage, because that's something right there. So how are you going to keep people over the long term interested and fresh and present with your intervention? Again, those are tough questions to ask. But on the flip side of it is there are some people who are so adherent that they will do whatever you ask them to do. And so you have to be mindful of those people and that you're not overburdening them. We made a real gross error, I think, in the BP track protocol, where we asked people to take their blood pressure twice a day, and at each sitting to take it 3 times, because that is the University of Michigan home monitoring blood pressure protocol. And so we've got people who are now taking their blood pressure 6 times a day, and there are some individuals who were so adherent to it that when they came back, we had just hundreds and hundreds of data points for them. And they were like, the one thing I didn't like was, man, it took a lot of time and energy to do that. And to think, well, really, did I need 6 data points every day? I don't know, probably not. So to be a little more mindful, that really taught me to be a little more mindful about what I'm asking people to do. Most people aren't going to do it, but some people will, and they're going to go above and beyond. In terms of provider lessons that we've learned, providers are super excited, but have a lot of concerns. Clinicians are already so busy, and asking us asking them to do one more thing is just really hard. And people I find are really supportive of the work that I do, and they want to participate, but they've got questions. They want to know, what do they need to do? How do they need to do it? How are they going to fit it in? What are they going to do with the data? There's a lot of that. And I think these are a lot of the questions that we need to start answering as we think about the future and how we're going to get there. There's a lot of process measures that need to be taken into account. And to think that clinical care is going to look like what it does today in 20 years, just with some technology thrown in, is kind of naive. We probably need to re-envision what some of our clinical processes look like so that we can get there. I was on a care at home task force at the University of Michigan a few years ago, and we were really talking about, by the year 2020, we want so many of our visits to be conducted in the home. We want to leverage remote monitoring technologies, and how are we going to get there? And they're thinking about low-hanging fruit that we can start picking and disease cases and use cases. And I asked the question, who's going to do the troubleshooting? Who's going to take the data in? Those are questions that we really need to answer for dissemination and implementation. How do we really put this into practice? Simulating ideal clinical use is often impossible, at least at my institution. I try really hard to do these demonstration projects in a manner where people can really emulate real-world, daily clinical duty models. But at the end of the day, it's never a good fit because none of this stuff integrates with our EHR. At the University of Michigan, we take a all-or-nothing approach. We will not pilot technologies for specific people or specific clinics. If we roll it out to one person, we roll it out to the entirety of the population that is serviced at the University of Michigan. And that's really difficult to make the work that we do in a real-world setting because at the end of the day, the clinicians who work with me are always working on multiple platforms when we all know that to have the best bang for our dollar, we need to integrate these tools into the electronic health record. So that's a really tough pill to swallow at times. Are physicians really the best recipient of patient-generated health data? We know that physicians are super busy. How are you going to fit this into your clinical practice? And really, are the docs the ones who need the data? In BP Track, we capitalized on clinical pharmacists. And are they the right people for the data? Are nurses the right people for the data? I don't know. I suspect that in 20 years, there's going to be a whole new class of healthcare worker who's trained to help support other clinicians in their use of this data. I could be wrong. I don't know. But I think that there's a lot of opportunity, and we need to think about who are the right people to use this data and what are they going to do with it. And then lastly, what are the ethical implications for use in clinical care? In our BP Track pilot, we really kind of took a mixed methods approach, and we interviewed the clinicians who worked with us, and we asked them, what did you think of it? And they all loved it. They loved that this data was coming in and that they could use it if they needed to. But our pharmacist had some real concerns because she was up at night, because she knew that Mrs. Jones was walking out there with some scary numbers. And she'd call her and say, Mrs. Jones, I see your numbers are really high. Is everything going okay? Are you feeling okay? Do I need to have you come in? Have you taken your meds? No, she hadn't taken her meds. So now she says, well, call me. I'll call you back in 4 hours. Take your meds right now and we'll see what's going on. Call her back in 4 hours. Well, the meds worked and she was probably dosed appropriately. But at the same time, what is our pharmacist's responsibility for helping people manage their condition? And, we don't know the answers to a lot of this. We now have this ability to have more data than we've ever had before. And how do we use it ethically and responsibly? And at what point do we intervene? These are a lot of the questions we need to ask. So I just want to take a minute as we run out of time to acknowledge that I have had some fantastic mentors. These are some of the mentors and colleagues who have really helped shape me in the work that I do. Again, I work with emergency medicine docs, I work with pharmacists, I work with physicians, I work with just about anybody under the sun, and I've had an amazing team of resources and mentors. So, any questions?
You mentioned the ethical considerations, having access to people's data. Have you done stuff in the mental? You mentioned you did stuff in the mental health world as well. I know that comes out of somebody endorsing depression symptoms or somehow is like having a psychiatric crisis, a mental health crisis. Has that been part of the story for you in the mental health work that you've done?
The hardest part of doing the mental health work that we've done is actually tapping into people with depression. First of all, the one thing that I've learned, again, not as a clinician, this probably comes as not a surprise to many of you, but even having depression documented in the medical record is spotty, which really shocked me. And I just expected we'd pull ICD-9 or ICD-10 codes for depression and we'd find the people we were looking for. No, there's a lot of people who just aren't coded as having depression for a variety of reasons. Some of them good, some of them not so good. And then when we reach out to people prospectively, I have a trial ongoing right now where we reach out to all people who have a new antidepressant medication prescription, and the number of people for the first time in my career who have accused me of HIPAA violations and wanting to report me to the IRB, and having been reported to the IRB now, and have compliance talk my participants down to say, no, really, this is an allowable use of your data, and they're above board, they're doing things by the book. I'd never had that happen before. So, I mean, there's a lot of stigma attached to it, and there are some people who are very sensitive. The other thing that I've also learned from doing that is, on the flip side, having a protocol in clinicaltrials.gov, the number of very depressed and very not well individuals who have reached out to me saying, can I please be in your trial, is very heartbreaking to me, because I know they don't meet eligibility criteria because we're only working within our own system. And that's been really hard for me because I've just never experienced that with my blood pressure or my type 2 diabetes research. And just having the number of people who email me probably on a monthly basis has been hard. So, yeah.
Well, first of all, thank you so much for this great presentation. My question is about the comorbidities of many of these patients, because obviously they have not only high blood pressure, but they have diabetes, et cetera.
Yep.
So are you trying to go like problem by problem, or are you trying to like say, if we do better by our diets, we're going to solve some of these other problems? Can you talk a little bit about comorbidity?
Yeah, and you're absolutely right. I mean, most of our participants are comorbid in many different things. And we have to date taken a condition by condition basis. Dealing with hypertension is hard enough. I don't know how I would layer on multiple disease states. But at the same time, I know there's a lot of work that looks at both depression and diabetes, hypertension and diabetes as they relate to one another. But at the end of the day, you know, we are intervening on the same types of behavior changes. And so, but to date, we've largely stayed individual disease state, just for simplicity.
And my second question is, you know, now you're interacting with a lot of different people, obviously through the NIH, et cetera. Can you talk a little bit about what's on the horizon?
Oh, goodness. So I think we're going to see more sensors. I mean, everybody's got a sensor for everything. And I think some of the sensor world is really exciting right now. And the ways in which people are using different sensors, things that, you know, far smarter people than I are coming up with. And those are some of my favorite review panels to sit on and see some of the new sensors that people are developing. And the implication and the application to lifestyle and behavior change, I think, is really cool. We've got some work that we're just getting off the ground now, looking at the use of continuous glucose monitors as an intervention point and educational tool for pre-diabetics, which I think is absolutely fascinating. And that's not something that I think is on the radar of a lot of people, because, you know, you think of CGMs and you think about type 1 and type 2 diabetics, not pre-diabetics. So I think we're just going to see a lot more sensors being used in innovative ways. Yeah.
I had a headline recently past my eyeballs and could not click on it, but it said something about insurance companies wanting to know how many steps you were taking every day. And so I'm wondering, along with the sensors and this data, and who has access to the data, and people not being willing to participate because they're thinking of these other uses that happen to the data. I don't know, any thoughts on all that?
Scary, scary stuff, I think. And I think people have a lot of concerns. And I think, you know, we're at a point right now where people are making their own decisions about what data they're comfortable sharing. And I'm really pleased that people are starting to get to the point where they have such literacy in these issues that they can think sensitively about what data do I want to share. I personally am a data open book, and when our robot overlords take over, I will be the first to fall because everything is out there. But at the same time, you know, everything is out there. And, you know, but for me, I will have lived a convenient life up to that point, and it was worth it in the meantime. But, you know, I think people are becoming more savvy about these issues. And, you know, the thought that your behaviors are going to get linked to things like reimbursement, that's a really scary pill for a lot of people to think about. And, you know, do I think we'll see it in my lifetime? I don't know. So, but the ethical issues of the use of these technologies is not to be downplayed. And there are tremendous considerations that need to be made. Yeah.
Question about, I'm sort of glad you mentioned the sort of design aspect of the technology, but how do you disentangle, like, for example, in your MyBP project, the impact of the design of the app versus the intervention itself? So I can envision a situation where it looks like the intervention was a failure, and yet it was really just the app being poorly designed and not the concept behind the intervention. So how do you disentangle that sort of in your study design and sort of your analysis?
It's a good question, and I think a lot of it comes into the engagement piece, because you have to ask yourself, is it that the intervention failed, or is it that you had such a crappy design that you couldn't engage people to use it? And with all that being said, I think we're at a point now where there's so many of these tools out there that it's really hard to make a blood pressure graph look different. And so I think we see a lot of similarities in the approaches that are out there. And there's a lot of design libraries that kind of show this is how we do this kind of thing. And, you know, for the most part, they're pretty easy to use. We're not doing anything that's so radically new. We're just packaging it differently and giving it to people in a different combination. And so, you know, this is actually a good question that I answer on a pretty consistent basis when it comes to MyBP, because I mentioned our vendor. We've had terrible problems with our vendor, and that people are really concerned about our intellectual property and what that means for the next study. Do we have to work with them? Do we work with someone new? And I'd argue that, again, there's nothing that we're doing that's particularly novel. And, you know, as long as you've got the APIs and we can show you a pretty graph of what your data looks like, you know, it may look a little different and the experience to get there could be a little different, but it's really not that complicated, and that's the important piece. Does that make sense? Yeah.
I think that's a really relevant question, because it's just like any scientific design or study, in the methods, when you specify the letter MyBP app version 3.2, whatever, because another app that couldn't do the same thing but tremendously clunky interface or experience may have zero effect.
Right.
And this intervention that this particular firmware version, whatever, might have an effect, and we just sort of have to describe it, and for better or for worse, when they update to another version, it might be better or worse.
Yeah.
But one approach that some people take too, and this is more done on the vendor side, A/B testing.
Mm-hmm.
So I mean, you could use the same app, version A test versus version B, and see if there are different outcomes.
Right. Right. Yeah, and we've certainly conceptualized different research studies where we're looking at testing components of interventions versus, you know, what, you know, design and whatnot. And I think there's a lot of work that needs to be done, and there's no loss of opportunity for doing that kind of work. And, you know, again, with my role in the School of Information at the University of Michigan, people are very anxious to do that kind of work because that's what they understand and that's what they know. Yeah.
One last question along these lines. So there's the vendor, who's the developer, who's designing, who's writing the back end of the app, but who's actually designing the front end? Is it your team, or you're saying we want this functionality and they're designing it, or is there like an interface design professional person who comes into it?
For the most part, we work with established vendors that already have products that have the core functionality that we're looking for, and then we'll say to them, okay, we really like what you're doing with your app, and you offer all the way from A to Z. I just want to use A, B, and C. And then here's the content we want to use. Here's, you know, how we want to design the messages, how we want them to fire. You know, we make those kinds of tweaks and adjustments. But again, we tend to work with vendors that already have the core functionality we need. It's just, I think, again, it goes to the feasibility of what we're asking the vendors to do.
Well, great. Thank you, everybody, for coming, and thank you very much.